Thank you for including us, and we're here to talk to you about how we've included lived experiences as part of health equity analyses. And I think we'll spend a little bit of time talking to you about what we've done, but we really look forward to the conversation later. We will start by sharing with you who we are. As you can see, we're a couple of people on the call today. We want to level set language because some terms that we may use in Canada may be different from what you use. So let's start off by using the same shared language. We'll introduce EMPaCT to you, talk about gaps and solutions, and then our 5 steps towards AHIA. Let's get started. These are our amazing avatars that we created during COVID because we didn't meet in person for around 2 years, and this was a way of expressing ourselves in a virtual world. So my name is Ambreen. I am a scientist at Women's College Hospital. I've trained as a surgical oncologist, but I now do 100% academia. That's because I believe research is the way to produce knowledge, and knowledge is the way to yield power. So how can we have knowledge that is, not just created by people who are in the ruling class, but really that involves everyone from all aspects of life? And that's what this conversation is about today. I study patient engagement, health equity, cancer care. I do a bunch of roles which you can read on my online profile. But really today it's an honor to be here with my dear friend and colleague Elise, because in June 2020 we sat together and scratched our heads, and it's been a roller coaster ever since. And so welcome to our journey. Also, who couldn't be here today is Linda. She was also with us from the start. She's been part of creating this presentation down to each and every dot and cross, but she can't be here this morning. And then I'll pass it over to Anam if you'd like to introduce yourself, Anam.
Sure. So thank you so much, Amreen, for the lovely intro for the slides. This is Anam Shahil Feroz. I'm doing my PhD from University of Toronto, and it was great to meet Amreen and to be able to contribute to such great work. So I will pass it on to Amreen again. Thanks, Amreen.
Thanks, Anam. Elise, how about you?
Okay, so my name is Elise Mabey, and I've been a patient partner since 2011. And I'm well aware that I am a person of some privilege and have been frequently asked the question, how do we engage with people who are not like you? So like Ambreen, I've been exploring the challenge of involving diverse perspectives authentically for the purpose of advancing health equity. And this is the shared vision that Ambreen and I have, and we brought us to co-initiating EMPaCT, Equity Mobilizing Partnership in Community. So happy to be here. Thank you. Okay, so we'll start with an understanding of what we mean by patient engagement and sharing our terms with you so that we're on the same page. Firstly, in Canada, we use the term patient engagement, which is the active patient and public involvement in all aspects of healthcare. So that's practice, policy, research, and education. And while it's not always achieved, the goal is an active partnership. Those like myself who contribute time and effort to share our living and lived experience of care are often referred to as patient partners. There are other terms, and the labels seem to be quite flexible and fluid. However, our common goal is to improve health outcomes and experiences for patients and caregivers. And I believe in the UK, you refer to caregivers as carers. In this presentation, we'll be using the term patient partners or patient caregiver partners. So now we're going to start by describing EMPaCT as a specific model for inclusive patient engagement. So let's look at institutional patient engagement. The institutional patient engagement we're mostly familiar with brings patient and caregivers to the healthcare table. We're invited into the healthcare environment on terms usually determined by the organization. The engagements are usually time limited in some way and focused on the professional agenda. In most cases, participation is voluntary, although we're being compensated more and more often nowadays. Meetings are held on the days and hours agreeable to the healthcare professionals and in the locations that they choose or that is chosen by academia. And the relationships with staff are often fragmented due to the episodic nature of all the projects. Over to you, Ambreen.
Thanks, Elise. So, as someone who is working out of an institution, very often all my funds and projects are my funds are held by the institution, and my projects are guided by the policies and regulations that the institution sets as a boundary around what can be done. What that inherently means is that I apply for grant fundings. The grant funds will determine the degree of the milestones that have been set in order to get the grant funds and the number of people that I can hire to bring on to execute a project. And what that inevitably means is if I have a short project with limited funds, I'll reach out to the closest patient partner within my circle, and we'll jump together on a project without really giving ourselves enough time to explore relationships and deeper aspects of meaning. And the institutional setting can actually be quite traumatic for a number of patient partners, and therefore we're really missing out on a bunch of things. And so this is the question that Elise and I were really scratching our heads over when we met. It's like when we have an institutional patient engagement model and setting, who are we really engaging with in these settings and whose voices are missing? What are the structural situations that lead to that exclusion? And what can we do about it? Because both of us don't like to talk about problems. We're both action oriented. So ultimately, it was about, well, what is this? What would a solution even look like? And to dig deeper in that, myself and Elise, we thought of the intersectionality wheel and began to unpack some of the lived and living experiences that are created through structural oppression. What does racism look like in these settings? What does oppression look like? What does colonialism look like? And how are these creating systematic barriers so that only very few privileged patient partners are making it to that table? And because we had our own embedded relationships within community before we even met, Elise and I would say spanning back to around 8 to 10 years, we were able to take those ideas and have conversations with our relationships in community about them, bounce back those ideas. Well, this is what Elise and I are thinking. What do you think? Does that make sense? Does it resonate? And it was really through this approach with very intentional, a very purposeful engagement of talking to people who are most excluded, which we define as equity-oriented outreach. So those that are most excluded are the ones we most reached out to, and using trauma-informed trust building. So being really conscious about those systems and structures of oppression and asking, well, what is it that, keeps us separated from institutional patient engagement, and what would make it worth your while? So we spoke to patient and community partners, and lo and behold, what we heard was, participation is by invitation. There's stereotyping, there's judgment, there's bias. Our voices are used as stories, and nothing really happens. But I think what I really want to show on this slide is that we weren't just talking to patient and community, because being action oriented, we knew that speaking to just patients isn't going to solve a problem. We really need to have an interdisciplinary focus so that all the stakeholders are involved in coming up with, possibilities around the problem and then coming towards a solution together. So this is what we did. We spoke to a variety of stakeholders, and patient community partners told us, well, if you're going to involve us, it needs to be for change. Institutions told us we're okay to mobilize for health equity, but we need to know how. And there was a real thirst to fund innovation, and that was the genesis of EMPaCT. Elise, over to you.
Yeah, so we don't label people or use the sort of prescribed categories to bucket them in because we believe that labeling people can be restrictive and sometimes even harmful. So our EMPaCT members are shown here. This is a clip from our website, and each of them have shared what they feel comfortable with and wanted to share so we can get to know each other better. What really unites us, however, is the shared value of helping to create an inclusive health system, one that is socially just and fair for all. We strongly believe that for this to happen, we need to hear from people with diverse lived experiences with a view to applying the health equity lens to everything. So as EMPaCT, we co-created a formal process, which you see on the screen here, for engaging with the research teams and the project teams who come to us for an engagement. We meet with the decision maker or the principal investigator and one or two key team members to coach them in the early days how to achieve the best outcome for the consultation. So the two blue items there are the scoping and prep meetings. The meeting with people ahead of time like this is a key to creating a safe space. And it's also where I use my power as a patient partner of privilege to help team members to set up the discussion in the best way possible. I encourage them, for example, to explain their project like they would to their grandmother around the kitchen table. And so in terms of the scoping meeting, the purpose of this meeting is to carve out the scope and really target areas that change can happen. So that's a scoping meeting. In terms of the prep meeting, we provide feedback on the content of their slide deck that they use. They have a couple of slides to prep the conversation, and we discuss ways in which the team can make the most of the consult and tailor their language so that there could be a really good discussion with a public audience, if you will. And then the green bar there is the community consultation. This is when those same people, the decision maker, the principal investigator, and the one or two key members of the team, will engage with us as members of EMPaCT in a virtual meeting room. This meeting is an opportunity for really authentic dialogue with community, learning about our perspectives and seeing how that can inform their project. If you go to the pink, they get, at the end of this, we pull together a written report which contains the key findings coming from our consultation and recommendations. And this goes to them within 6 weeks of the engagement. And then finally, to tie everything up, we ask them to provide us feedback so that with telling us what the changes were that occurred as a result of the engagement. And that allows us all to learn what the impact was that we did and how to make things better.
Thanks, Elise.
Over to you, Ambreen.
Yes, I'm just going to add, and thank you so much, Elise, for really breaking this process down. And it really is about process. One of the things that we realized very quickly is we all know what the problem is, that we're not engaging in a diverse and inclusive way. And the big question was, well, how do we do it better? And for us, as we co-designed with community, it became very apparent that the devil was in the details, right? Like it's about process, 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 process. And this is what this slide shows you. And those are the steps that Elise has drawn out for you. All of these processes have been co-designed with community, with so much intentionality given to each and every step, whether it's preparing for the meeting, whether it's coaching people on how to approach others from a human to human level rather than a professional to person in the community level, which can often be quite loaded in terms of conversation and understanding. And then how to really set everyone up for relationships, because we want those relationships to move forward in a trustworthy and authentic way. Carving out the process for the written report was important because that way we get to document everything that happened in an engagement between decision makers and community partners. So no decision maker can really say, well, we heard it, but we forgot. Rather, you heard it, we wrote it, and now you have it. And then the feedback report enables that looping back to members of community so that they don't feel tokenized and that trust is built. Ultimately, every project needs to be involved in some pathway to change, as our patient partners identified early on. Unless there's a clear pathway to change, there's really no point in engaging at all. And then very, very quickly over this slide is a big piece of co-design was thinking from the outset that this isn't going to be a pilot project. We need to have a model of spread and scale so that whatever we co-design can be spread and scaled in other contexts and other scenarios. So thinking intentionally about the scale-up idea and what that entire pathway of spread and scale should look like when we come to the point where we are at right now, which is 4 years in, and we're spreading and scaling in 2 different jurisdictions. So a very exciting point in our journey where we're now recognized as a new way to engage with patient and community partners for promoting health equity that is scalable.
As a non-traditional model of patient engagement, we flipped the paradigm so that the decision makers request a seat at our table, at the EMPaCT table. Most models of patient engagement require us to go to the healthcare table or the research table. This community model flips that paradigm. And in this model, the community table exists independent of any projects and the healthcare projects are brought to us. It also serves projects across multiple healthcare organizations and does not just serve one entity. So EMPaCT is both a community table and a model. The table was co-designed by community and has grown organically, as Ambreen was saying earlier, through relationships. And it continues to evolve as the group decides. The table is an example of the model that developed in response to the challenges of institutional patient engagement that they have with including diverse voices. It's a community-formed table on its own terms with a focus on health equity. And we currently service groups, as I said earlier, both within our affiliated hospital and outside it, and even nationally. Healthcare professionals with ideas or projects contact us and they bring their work for a consultation. This makes EMPaCT a safe space for the community members who've been perhaps uncomfortable or even harmed in the healthcare environment, and where they may not have been guaranteed to be heard. There's also strength in numbers because we are about 17 people and the comfort of a trusted community, and we all know each other quite well by now, where our individual voices are respected and listened to, where we share experiences and get to know each other better and better. And we respect each other's differences and actually delight in some of the unexpected connections that we have with each other. During the consultations, we also can share insights without necessarily needing to expose vulnerabilities. So just putting a homeless person or an LGBTQ plus person onto a project does not allow for the long-term building of the trusted ongoing relationships, which are really the foundation for sharing deeply the experiences that matter. Ambreen?
Thanks, Elise. So this brings us to the meat of the matter for today, I guess, which is the conversation around health equity assessments. And very briefly, what are they? They are tools and decision support making frameworks that have been designed to, allow people to think in a structured way about the health inequities that could arise as a result of a possible program, policy, or solution, and to think of mitigating factors so that we can, take some effort to reduce those inequities. They can be used to inform policies and to evaluate effectiveness of programs. With that being said, who is currently using the HEA tools? I myself have used a HEA tool as a policymaker, as a researcher, but they're used by program planners and by health professionals. Elise, you're on mute.
Sorry, we can do better. I can do better by involving the voices of community members, as we have done with EMPaCT. So let me give you 3 examples of how things have happened for us. One research team came to us, for example, to see how they could engage with a diverse set of people in their work around primary care. EMPaCT pointed out that for some communities, their go-to for primary care was the walk-in clinic and not a primary care doctor. One of the researchers came from a culture, indeed, that used mostly walk-in clinics, and she hadn't seen it, even though it was her family norm. The aha moment for the researchers was realizing that unless they involved the walk-in clinics in their work, they would be missing an important element in their research on how people first engage with care. So they extended their research as a result. My second example is another group that wanted feedback on their project to collect and record demographic data. And as you probably have experienced yourselves, collecting race-based data in particular has its challenges. EMPaCT pointed out that in many cases they responded with a prefer not to answer option or outright lied. And they suggested that the team investigate the significance of the prefer not to answer responses to understand why people chose that option and to adjust their project based on the results. And the team undertook to do this. My third and final example is, we had many groups coming to us about virtual care options and how to implement them, particularly during the period of COVID. But one group was looking for an option of offering virtual care through libraries. And EMPaCT pointed out that libraries were not set up to provide the privacy necessary for people to feel safe and comfortable. They were also not open all the hours needed for folks who were perhaps on shift work or had other time constraints. And they didn't have the supports necessary for folks with linguistic and other challenges. The group understood from us that they would need to dig deeper to understand all that would be needed to make the library option viable, and they undertook to do this. So those are the examples that we can share with you.
Thank you, Elise. And so with that, I'm going to pass it over to Anam to talk to you about a co-designed process to do a health equity analysis with community. Anam, over to you.
Thanks, Ambreen. So I will get started from here. So before we, understand this process, I just want to say here that many research teams and decision makers really want to do, more inclusive and equity-driven patient engagement, but oftentimes they struggle to do so without the appropriate tools and skills and resources that can help them, do equity-engaged patient engagement. Members of EMPaCT has co-developed this process that really embed health equity analysis into the projects that researchers want to do to help them ask more meaningful questions, modify their research designs, and recruit participants more inclusively so that the research outcomes can be directed towards improving health equity in whatever the work that they are doing. So as you can see here, the process involves 5 key steps, and it starts with thinking about the context of the project. I will be talking about each of these steps in my upcoming slides. Amreen, can you turn to the next slide? Thank you. So this is the step 1, where the focus is about on thinking of the context of the project. In this foundational step, the efforts are initiated to deeply comprehend the intricate context surrounding the project. The participants embark on a journey to uncover both apparent and subtle inequities that exist within the project context. And through collective efforts, the participants identify some of the visible as well as the hidden inequities that are surrounding the project. The steps also involves brainstorming on underlying structural conditions that continue to contribute to the inequities and their causal pathways. So some of the questions that researchers or decision makers can ask while working on this particular step include: what are the primary demographics and characteristics of the population affected by the project? What are some of the evident health inequities that may arise from the project implementation? Are there any subtle or less obvious inequities that the project decision makers need to consider? Also, the project team also work around understanding some of the factors like race, ethnicity, gender, socioeconomic status, geography, and disability that all has a role of contributing to different health inequities. So these are some of the questions, some of the prompts that researchers and decision makers can use to think more about this particular step. So to understand this step better, that how we can actually understand the context of the project, here is a hypothetical case study, which is about implementing virtual care services in healthcare organization. And the main objective of this is to implement virtual care services to expand healthcare services to patients, especially those in remote and underserved areas in the setting, to provide them more convenient healthcare outcomes and healthcare options that they can use to improve their healthcare outcomes. So for instance, to understand the context of the project here, the researchers or decision makers would like to understand what are the patient demographics. Are patients residing in rural areas? What are the number of or percentage of elderly individuals living with mobility challenges? What are the individuals that are living with chronic diseases, and what are complexities that they are, facing while living with those chronic conditions? And also busy working professionals seeking, accessible healthcare options, maybe later in the evening or at night. So all of these patient demographics can be considered under the context of the project. The other thing that the researchers or decision makers would like to do is to understand what evident health inequities are, like limited access to healthcare services in rural or remote areas, like less number of health facilities or maybe community workers that can help with the access, or what are the disparities in healthcare access based on socioeconomic status and geographical location, or what are the difficulties faced by individuals with mobility issues, mostly among elderly. Also, the researchers and decision makers can focus on understanding subtle inequities like digital literacy issues that are not always obvious, language barriers that usually people face in using health apps, or maybe reading those pamphlets that are available at the healthcare facilities, or what are the limited technological, access barriers that are there in the population. So all of these can be understood, and these are just some examples that can be used to understand the context of the project. The step two in this process is about understanding and thinking more about the project. So here, the researchers and decision makers try to understand the goals and anticipated outcomes of the project. And some of the questions that researchers and decision makers ask during this step can include: what are the anticipated outcomes of the project in terms of promoting health equity or addressing these inequities that they notice in their work? How might the project positively or negatively affect various demographic groups within the community? What are the unintended consequences or unforeseen outcomes that might arise from the project or the work that they are doing? And how can we anticipate and mitigate these, negative impacts of the project, particularly for the vulnerable populations? So let's try to understand this through the case study. So as we just talked about, that the case study is on in implementing virtual care services in the healthcare organization. So to understand, to think more about the project in step two, the first thing would be to understand what is the anticipated impact of the project. And the aim is to promote health equity by providing equitable access to healthcare services regardless of demographic characteristics or geographic location or other, other parameters that we have. Also, the project implementers would like to think about the unintended consequences of the project, like exacerbating health inequities for individuals with limited technological literacy or access to technology, or maybe just doing beneficiary analysis to really understand who are the beneficiaries that we are hoping to benefit through this project, like individuals in rural or remote areas or others. The step three is more about thinking about the change. And I would say, I will say that this is the most important step where researchers think, or decision makers think more about, how the change can happen, and some of the changes that they can make by intervening at different levels. Like they can work on the structural intervention level, or they can work on intermediary causal pathways, or improving healthcare services, or by making changes to have more impact on overall health. So some of the questions that researchers can ask themselves, or just decision makers in general, can include how we can address the root causes of these inequities that we are observing within the project, with the ultimate goal of improving health equity. What specific policies or initiatives can be implemented to ensure equitable access to education, employment, housing, or whatever they are working in? What material, psychological, or behavior factors that would be needed to target to mediate the impact of structural forces on health? So all of these, questions that they can really ask to understand the step three, or to think more about the change that they would like to do. So to understand this from the similar case study, there are some of the structural interventions, example of some of the structural interventions that are given here. It's like implementing policies to ensure equitable access and implementation to technology, policies to have good internet infrastructure in the setting, to establish telecommunication infrastructure in rural areas. And in the meantime, when implementing these structural interventions are always not easy. So researchers and decision makers can think about intermediary pathways that they can work on, like developing community programs to promote digital literacy, having community hubs to provide access to devices to these community members, or having subsidies for digital devices for low-income individuals. So the step 4 is about thinking about the recommendations. And in this particular step, the researchers and decision makers formulate recommendations based on the insights and discussions generated throughout the preceding steps. The group collaborates together to work on the actionable recommendations that they would like to do, or they would like to suggest for their own projects. And some of the questions that they can ask: what recommendations they would like to make to ensure equitable health outcomes? And what are some of the recommendations that they would set aside for now for further exploration or consideration in the future? So it's just about, recommending those recommendations to ensure equity in the project. So to understand this from the same case study, like for instance, implementing targeted outreach programs to promote virtual care services among underserved population can be one of the recommendations, or enhancing language accessibility or cultural competency in virtual care platforms can be another. And the last step, which I think is what most important to close the cycle, is about thinking about communicating how the group would like to communicate the findings of the project to various audiences, not just the academic, but the other audiences, the lay audiences, those who are in representing different groups. So the researchers can ask some of the questions like, how and why our findings be communicated back to the communities those are affected by the decision? And do we need to consider other channels of communication to help advance equity in this issue? So it's mainly about understanding how to communicate and what different channels to use to communicate. In this case study, a researcher or decision maker might decide to communicate their research findings through community forums or social media platforms, which has wider reach and wider access, maybe interactive workshops and training sessions with healthcare providers and patients, and maybe, thinking about disseminating their work through arts, theaters, radio shows, or maybe TED Talks, op-eds, videos. There are so many different ways that they can think of while for disseminating their work. Thank you so much. I will pass it on to Ambreen.
Thanks so much, Anam. And I'll just briefly go back to your slide of the 5 different steps. And I think one of the things that we want to point out is that each of these steps traditionally are done by the project implementers and program evaluators. The way we've co-created it with communities so that you're thinking about these 5 steps and all these prompts with people who have lived experience. And we're creating a safe space where decision makers and people with lived experience can come together and go through these prompts and questions together. So, for example, if we're thinking about change, it wouldn't just be a decision maker making hypothetical assumptions about what needs to change, but really people with lived experience, people who understand the context of where they live, work, play, and pray. And so that they're able to build that into the decisions and recommendations and nuanced understanding around the project. Even when it comes to communicating, we've had really interesting conversations around, oh no, you don't want to use that platform. Have you considered using a subway poster? Or have you considered, using this radio channel? So everything is essentially incomplete without incorporating the lived experiences of those who are ultimately bearing the brunt of those inequities given their structural circumstance. So this is what we like to call our show off slide. And I won't get into the details, but I think what's really evident over the past 3 or 4 years is that we've filled in a huge knowledge gap. This has been a new way to do health equity analyses that people haven't been able to leverage because of their project cycles, because of their own training, because of their lack of relationships with community. So EMPaCT has been a community table model that is able to plug and play into ongoing decisions within the healthcare system. And therefore, we've engaged multiple decision makers, whether in Toronto, whether in our province of Ontario, and even at the pan-Canadian level. So how have we been able to influence each of these decision makers in their project pipeline so that they're making decisions that are more inclusive and striven towards a goal of equity and social justice? And with that, I'll pass it over to you, Elise.
Yeah, so regrettably, Linda couldn't be with us today, but in the absence of her not being here, I'd like to read her quote. And she says, health equity isn't just about getting people through the doors. It's about understanding complex medical information, navigating online portals, and making informed decisions about our health. I've seen firsthand how these overlooked issues can shape our healthcare experience. We need to recognize the diverse needs of our communities and ensure that healthcare is accessible and understandable to all, regardless of literacy or language barriers. I really think Linda has sort of captured the importance of our work with that quote. And so I'll pass it back to Ambreen. Thank you.
Thanks, Elise. And we'd just like to acknowledge, our generous funders who've supported us from start to where we are today. And with that, we're done with our presentation and we look forward to a conversation.